Hello everybody, my name is Dr. Mohammed Hidari. I'm a specialist dermatologist working in Dubai at the Iranian hospital. The topic that we are going to discuss today is basal cell carcinoma. Basal cell carcinoma is by definition the most common cancer in humans, and the condition happens mostly in elderly men who are living in different parts of the globe, specifically in people that are chronically exposed to sun and have fair skin. By definition, the condition is rare in black or brown skinned individuals. The condition or the tumor is very slowly growing destructive lesion, which leads to local skin damage. However, metastasis or distant spreading is extremely rare, and it makes the tumor very easy to treat if it's diagnosed in its early stages. Now we can talk about the risk factors that make individuals susceptible to development of basal cell carcinoma. As we discussed earlier, this condition or this tumor is mostly prevalent in the people over 40 years of age. It specifically happens in the skin phototypes group 1 or 2. I mean, fair skin people are mostly affected by the condition. By definition, it happens in albinos, people that are suffering of albinism, because the amount of pigment in these people are zero or very less. If a person has a history of similar tumor or any other skin tumor, then the possibility of having the new basal cell carcinoma will be even higher. On the other hand, if there is some injuries, old injuries in the skin, like thermal burn, like lupus erythematosus, or even sometimes cutaneous tuberculosis, these people also are at risk of development of basal cell carcinoma. Some environmental factors also could play a role in the development of the tumor. For example, people that in their life exposed to ionizing radiation, radiotherapy, or some chemicals like arsenic, they definitely will be more predisposed to development of basal cell carcinoma. As maybe you know, immunosuppression can predispose to any type of tumors. Same happens with basal cell carcinoma. There are some genetic conditions or syndromes that make the person ready to develop basal cell carcinoma. There are some different names. I just list these conditions. Basically, there is a syndrome, basal cell nevus syndrome, that are there is many different symptoms and signs. Of course, people with xeroderma pigmentosa and basic syndrome, and finally Gorlin syndrome. Why the basal cell carcinoma happens? The pathogenesis is rooted in the DNA mutation in some tumor suppressor gene. Clinically speaking, the tumor is very slowly developing skin growth, which can be categorized in 5 subtypes. I will mention these subtypes. Most common subtype is nodular basal cell carcinoma. Basal cell carcinoma, nodular type of basal cell carcinoma is early translucent nodule or papule. Actually, in very early stages, it actually is a papule, but later on becomes nodule because the infiltration and the deeper tissue makes the condition to looks like a nodule. It could be skin colored or reddish, may be associated with surface telangiectasia, I mean dilated blood vessels on the surface. Sometimes becomes ulcerated in the center, and most commonly happens in the center of the face. There are some areas that are high risk area for development of tumor, including around the eyes, I mean near the conti, around the nose, and behind the ears. The second subtype of basal cell carcinoma is ulcerating basal cell carcinoma. As the name suggests, the tumor is associated with ulcer, or predominantly is defined by ulceration. So there is an ulcer which is covered by with a prominent crust. Sometimes we call it as rodent ulcer, and it could be associated with classical features of nodular basal cell carcinoma also. We can find a pearly characteristic border, translucent quality of the lesion, and dilated blood vessels on the surface. All can be found in the tumor. Sometimes ulcerating basal cell carcinoma tends to be very big and deep and destructive. A third subtype of basal cell carcinoma is sclerosing basal cell carcinoma, or morphic BCC. Most commonly, we can find this type of tumor in the mid part of the face, and by definition, it is associated with fibrosis or sclerosis of the skin. As you know, morphia is a condition of the skin and associated with deposition of collagen and fibrosis under the skin. That's why we call this type of tumor morphic. One of the significant characteristics of this tumor is its tendency to extend subclinical. I mean, it's much more extensive than the tumor that we can see in the surface. And also, this tumor tends to spread along the neural plexus of the skin. So we have to consider these facts when we are dealing with this tumor or when we want to remove the tumor. Next is superficial basal cell carcinoma. This subtype of basal cell carcinoma is specifically more common in younger people and also mostly can be found in the upper trunk area. The other subtypes are mostly on the face and high-risk parts of the face and neck, but this particular subtype mostly happens on the upper trunk. Most obvious characteristic of this tumor is the thread-like border. When we find thread-like border in a scaly plaque over the trunk, we can think about possibility of basal cell carcinoma. Mostly it looks like eczema or psoriasis and often bleeds when we touch it. Even slightly we touch the tumor, it tends to bleed. The last subtype of basal cell carcinoma is pigmented basal cell carcinoma. As the name suggests, the tumor is associated or it tends to have a lot of pigment. And then we can easily found that the condition can be confused with other pigmented lesions, specifically malignant melanoma. So differentiation from malignant melanoma sometimes is a challenge for the clinician. By the way, the tumor has a smooth and glistening surface. Sometimes the amount of pigment is a lot and tumor looks like blue nevi or even it's black. Diagnosis of basal cell carcinoma mostly depends on clinical suspicion. However, skin biopsy with histopathology examination is the most commonly used procedure for the diagnosis. So when we send a sample to the pathology examination, under the microscope there will be a solid tumor with proliferating atypical basal cells, which are large, oval, and deep blue under hematoxylin and eosin staining. And interestingly, the amount of mitosis and anaplasia is not that much, or it actually is rare. One of the characteristics of the basal cell carcinoma is palisading arrangement at the periphery of the tumor. And the last characteristic of the tumor is mucinosis, mucinous stroma, or deposition of the mucin around the masses of the tumor cells. That is, of course, a variable finding. We have another tool for diagnosis of basal cell carcinoma that will help to make the differential diagnosis even more narrow, which is dermatoscopy. Actually, dermatoscope is a magnifying lens that we use in clinic for diagnosis of pigmented lesions, but also it can help for diagnosis of non-pigmented lesions, including basal cell carcinoma. Features that are in favor of basal cell carcinoma diagnosis are absence of pigment network. Actually, pigment network is very common finding in pigmented lesions, but in basal cell carcinoma we cannot find it. And as we mentioned earlier, there is superficial dilated blood vessels or telangiectasia on the surface, which is very prominent under dermatoscope as well. Differential diagnosis of the malignant tumor could be very wide, but we can consider at least some of these benign or malignant tumors in differential diagnosis. Dermal melanocytic nevi, trichoepithelioma, dermatofibroma, malignant melanoma, specifically can be confused with pigmented basal cell carcinoma, and squamous cell carcinoma, which can be confused with ulcerated basal cell carcinoma. Management of basal cell carcinoma mostly is by surgical excision. Actually, surgical excision or radical excision of the tumor is the most commonly used procedure for treatment of the lesion, and it's most appropriate treatment for the nodular and morphic subtypes. But when we remove the tumor, we need to include between 3 to 4 millimeters of normal skin margin as well. Sometimes the lesion is quite big and we need to perform flaps or grafts to cover the defect that we created by surgical excision. If the lesion is of morphic subtype and infiltrates deeply, the best approach is not just to the surgical excision. Is actually we have a specific type of surgical excision which is called MOHS surgery, MOHS surgery. In that procedure, we control the margin of the lesion microscopically while we are removing the tumor to make sure that we remove enough surgical margin. Because as we mentioned earlier, morphic basal cell carcinoma tends to extend much more in subclinical area. Subclinical extends in much wider area. In addition to classical surgical approaches, we have superficial surgical procedures, including shave excision, curettage, and electrocautery, that are appropriate when the tumor is very small or in superficial type of BCC. Also, we can perform cryotherapy. In cryotherapy, we use liquid nitrogen in order to freeze the lesion, and then later the lesion will, the tumor cells will be damaged. Also, this type of procedure is only appropriate when we have BCC on the trunk or limbs. But unfortunately, it can leave a permanent discoloration on the skin or permanent white scar, which will be with the patient for life. We have medical treatments also, including 5-fluorouracil and imiquimod cream, which can be used only for some superficial basal cell carcinoma. Usually we apply these medications, these creams, 5 times a week for a period of 6 weeks. And finally, we have photodynamic therapy. Photodynamic therapy uses visible light, like blue or red light, after using a photosensitizing topical medication on the lesion. That's also effective in superficial type of basal cell carcinomas. Finally, we can talk about course and prognosis of the BCC. Usually BCCs cannot do any metastasis, and most of these lesions can be removed easily with surgical techniques. So we can say that the basal cell carcinoma usually cannot affect the patient's survival. However, some of the basal cell carcinomas are more challenging, specifically if it happens in the danger areas of the head. That includes around the eyes, behind the ear, and near the nose. Or sometimes if the tumor invades very deep and causes significant destruction of muscle and bone, and sometimes it's so deep that it can reach the dura mater of the brain. In such cases that the tumor is not easy to remove, we can use some of the new biological treatments for the control of the condition. I hope this discussion will help you to be more familiar with the skin tumor, specifically basal cell carcinoma. And I am very happy to discuss this topic today. Hope you enjoy the topic. Thank you very much for being with us.